Hello, and thank you for joining us for another CEU as a part of this year's Care for You 2. That is the annual conference put on by Resolve Counseling and Wellness. This year's theme for the conference is Reclaiming Joy, Purpose, Presence, and Renewal. We hope that you've enjoyed the CEUs that you've gotten to see so far, and stay tuned because this particular one is about culturally responsive suicide prevention, specifically supporting BIPOC and LGBTQ communities. My name is Jessica Doan. I am a licensed clinical social worker. I am also the director of community engagement here at Resolve Counseling. I am licensed in both Kansas and Missouri as a clinical social worker. I also went to the University of Kansas for both my undergrad and my graduate degrees. And some of my specialties in the therapeutic world are working with LGBTQ plus folks, healthy relationships of any style, stress reduction, burnout, identities of any kind, and of course, your typical anxiety, depression, perfectionism, and ADHD in women. Today, we have several objectives. This is a little bit of a heavier topic. I think anytime that you're talking about suicide awareness and ways to respond appropriately, it's going to feel a little bit heavy. So I want to first just give you the reminder that if you need to pause or step away, that is absolutely encouraged throughout this presentation. One of the beauties of a pre-recorded presentation is that this is on your time. So if you start watching and you're having a tough time with the content, take that as a moment and as a sign from your body that it is not meant to be watched right now. I have a lot of really great content to share with you, and I'm excited to dive in. So, our objectives for this training are we're first going to work on identifying cultural and systemic factors that influence suicide risk. We're going to recognize protective factors that are unique to the BIPOC and LGBTQ communities. We're going to use culturally responsive assessment and safety planning strategies and talk through some of those options for you as a provider. And then lastly, we're going to figure out ways to integrate affirming practices into crisis response as well as follow-ups. So why does this matter? I always like to start my presentations by giving a little lay of the land so you can understand why the topic at hand applies to your day-to-day work. One of the things here that's important to notate is that systemic issues such as discrimination, stigma, and historical trauma are not just background noise for these populations. They're actually very relevant risk modifiers from a clinical lens. So what we know is that LGBTQ youth are 4 times more likely to attempt suicide than their peers. That's a really large number, 4 times more likely. We also know that BIPOC individuals face barriers in accessing mental health care, which increases risk. Um, Identity plus systemic oppression affect risk and access to care. We'll get more into that a little further into the presentation. We also know that marginalized groups often face unique challenges and stressors that increase their vulnerability for risk of suicide. And then culturally responsiveness improves engagement, safety, and outcomes. And as mentioned in our objectives, we'll talk about that towards the end of the presentation. Before diving in further, I want to talk about something called intersectionality. This might be something that you're super familiar with, and if not, here is a refresher or an introduction for you. So one thing here is that intersectionality, by definition, is the overlapping of identities. So whether that be race, sexuality, gender, class, disability, this changes how people experience stress and also how they receive support. Something here to think about, for example, is like a Black transgender teenager, for example, might face racism on top of transphobia and the family rejection piece for their identity. We also know that within BIPOC communities specifically, or even more specifically within this example, within the Black community, there can be an additional stigma about sexuality. So, in our example, we are looking at multiple overlaps as to why this particular teenager might be facing an increase in suicidality and risk. So, when you've got multiple different identities that are being treated conflicting. That doesn't make sense. If you have multiple different identities that are stigmatized, that layers on top of one another. So, not just does this teenager have to struggle with racism and historical racism that is still very much so deeply built into the systems that we're a part of, but this teen in the example also is struggling with dealing with being transgender and living in a world and in a society that silences that identity and makes it dangerous to be identified as trans. So, as we continue to move through this presentation with the thought of suicide on our mind, we really have to consider how someone's natural identities increase their risk factors and decrease their support factors just right off the bat. The clinical implication of this is that we always need to assess the whole person and not just one identity in isolation. So, with this particular example that I'm chatting about, we've got a Black trans teen. So, we need to focus not just on this kid's transness, but also on their Blackness. And we need to focus on how those two things intersect and how that can create additional barriers and struggles for this person. Again, we'll talk more about this throughout our presentation, but I really want to just lay the groundwork up front so you have a scope that we're viewing this info from. So next, I want to talk to you a little bit about cultural and systemic risk factors for both of these populations and communities. One thing that we need to talk about here is something called minority stress. So, minority stress refers to the additional stress. So, additional is important there, but the additional stress experienced by individuals belonging to stigmatized social categories due to their minority status. This stress is chronic. This is also socially based and goes beyond the general stressors that people encounter in their lives. This is not something that every single human being experiences. This is specifically experienced by those in minority groups. It's incredibly important that we keep that on our mind as well throughout our presentation and also when working with folks of different identities. We know that these things also co-occur with the classic individual risk factors. So not only do we have the risk factors like hopelessness, intent, plan, but you also have the risk factors that increase that coming from a lens of minority stress. So something to keep in mind here is that there is ongoing discrimination and microaggressions that folks are actively experiencing, sometimes on a daily basis. So with that minority stress model that I was just talking about, there's also some internalized stigma. That means that there may be people that we're working with that are experiencing stigma from the outside world saying, something's wrong with you, or you're not right, or this is a stereotype about the kind of person I know that you are based on your identities. So we've got the external, but then there's also the internal. Folks are hearing these messages throughout their entire life. They're treated differently in spaces. They have a lack of support in other spaces. So we really have to consider how these two things layer together. Technically, these three things, right? The external, the internal stigmas, and then the minority stress on top of that. We also can't talk about this without identifying that historically there are levels of trauma for both of these communities. So within the BIPOC community, we know that there's historical trauma related to racism and segregation. We know that the civil rights movement is something that runs deep throughout families and generations, and we know that it has impacted different folks in different ways throughout time. The way that history has been written, the way that we've been taught history growing up is also full of stigma. Within the LGBTQ community, you've got the historical and community trauma of the Stonewall riots. You have the time in the 60s where gay folks were not allowed to be seen together. If you were seen together as two people who could be identified as gay, you were arrested. Our communities, so within these minority communities, what we know is that that trauma, although it maybe wasn't even experienced by the person you're serving. So if you're working with a teenager in 2025, obviously they weren't alive for the Stonewall riots. However, that trauma that's built within the community has shaped the way that we move throughout the world if you have these identities. And I think that that is something that we lose sight of a lot, is how our history has been deeply embedded into our systems even when time has changed. So, as time has changed and things have progressed, these pieces of our history continue to show up and continue to be acceptable in places, um, which is really unfortunate. Something else to think about here is how does that increase barriers to competent care? I I hate to draw attention to this, but this is something that I see quite frequently. It is running into, is this provider safe for me to refer my client to? When I'm looking into different levels of care, or I'm looking into different types of medical procedures or additional services that might be beneficial on top of therapy, I have to think, is this a safe referral? We'll talk more about that a little bit further into the presentation. But one of our risk factors is simply that there's not enough care providers who are trained appropriately to be competent in treatment for different communities, which is why trainings like this are so important. It's not because we're expected to know everything. It's not because I think that everyone on this planet needs to know everything about everyone who's different than them. But what I do know is that when you are a person with some of these different identities that are highly stigmatized historically and present day, that going to a provider who doesn't understand your background, your community's history, why things matter to you the way that they do, it makes that safety and trust nearly impossible to build. There's nothing more frustrating than going to a doctor's office as a queer person and having to explain why I don't take birth control pills. There's nothing more frustrating than working with a trans client who goes to see a doctor who then has to explain what it means to be trans to their provider. There is nothing more frustrating than being a Black woman trying to receive health care and being continuously told that nothing is wrong with you, when we know that statistics show us that Black and brown folks are given less quality medical care and therefore have higher rates of younger death. We know that these things are happening, and that is just the beginning. So please keep that in mind as you're learning more and as you're exploring more throughout the people that you're working with, is there are so many nuances that are incredibly important to capture, and we can't overlook them, specifically when we're talking about suicidality risk and protective factors and safety planning. And then the last one that's a pretty major risk factor for many folks is social isolation or family rejection. Social isolation might show up in a lot of different ways. Maybe the client is a person of color and they live in a predominantly white neighborhood. They might feel social isolation in that regard. Maybe it's a queer or trans person who comes out and their family says, we can't support you. We can't have you be in our home. We can't have you be with your baby cousins because we don't believe in that. These things all layer together on top of the regular risk factors. Depression, anxiety, the stressors of being a student, being an employee, being a parent, being a sibling. We all carry so many different roles in our life that make it naturally challenging to keep going sometimes. However, we need to remember that folks in different communities that have historical trauma and also have the minority stress, that is an added, multiple added layers to the weight of the world or the weight of life. And that is, I keep saying it's incredibly important, and I can't stress that any differently. It's important that we keep these things in mind because these things layer on top of the things that we are already assessing for when assessing for suicide. But on the flip side, these communities also have protective factors that are specific to them. We lose sight of this often as well. I know I'm harping on how important it is to see the quote unquote disadvantages these communities have, but it is just as important for us to focus in on the protective factors that are specific to these communities. So, for example, some of the key protective factors are that there can be a stronger sense of community or chosen family ties for both BIPOC and LGBTQ folks. This might look like community elders. So, for example, a young trans teenager seeing an elder trans person can be one of the most life-changing things because what that experience has done is it has shown that young person it is possible to be old as me. It is possible to make it through this part. It is possible for me to live my life authentically. Many queer kids specifically think that they're not going to live past the age of 18 or 21. Um, and so being able to see an elder who looks like you or has similar lived experiences as you gives hope. We also see positive cultural and spiritual identity. Faith leaders can be a really wonderful support within the BIPOC communities and the LGBTQ communities, depending on the space, of course. Um, there are also specific cultural healing practices that might come into spirituality that might bring a sense of hope or safety to folks from these varying communities. Having access to affirming and safe services is a protective factor. So while we still have a long ways to go, we also do have affirming, supportive providers within even the Kansas City metro area. We have a lot of wonderful providers that are skilled in these areas, and that makes a massive difference. And then lastly, having culturally coherent coping practices. Um, there are going to be specific coping tools that feel more aligned with someone's values or their lived experience if it is also tied to their culture. So this may look like a lot of different things. It might be prayer for one. It might be a community event for another. Maybe it's a peer support group for LGBTQ youth or parents. There can be a lot of beautiful active connectedness within these communities and cultures. And so while you're assessing for the risk factors, also assess for the protective factors. Draw attention to the things that are specific to these communities. Because again, we see the stories of the tragedies, we don't always see the triumphs. And this is a beautiful way to highlight that for folks that are struggling. While speaking about this, we need to also think about our warning signs. So, warning signs for suicide might look different for different communities and different populations. Something that we know is that common warning signs, such as withdrawal, mood changes, and talk of hopelessness, is just one. So, I mentioned a few slides ago that we need to think about the risk factors that exist for folks with suicidality in a general level and also from a cultural lens, this is very similar. So your warning signs for suicide are going to be the same, but also different. So that withdrawal, mood changes, and talk of hopelessness, for example, if someone really heavily relies on their community and they show up to events and social circles, and then all of the sudden they stop, that is a big red flag. If people are withdrawing from the safe supports that they've created or the chosen families that they've developed, that is even, in my opinion, a larger warning sign than withdraw from peers at school, for example. So please, again, I keep saying, keep this in mind, but keep that in mind. We also know that we see changes in spiritual and cultural participation. That's literally what I just said. So maybe seeing a difference, maybe you're working with a trans teen and they stop dressing like their gender and start dressing like their sex assigned at birth. So maybe they start withdrawing from their identity. Maybe they come to you and they say, you know what, I think that I need to stop going by my chosen name. It doesn't feel safe anymore. I'm sick of dealing with it. I'm sick of feeling like I have a target on my back all of the time. So you may start seeing people step into these protective roles for themselves as a warning sign. Make masking emotions due to the stigma within the Black community, within the Hispanic community. Um, we we hear or we see, I can't say I know because I recognize that I am not a part of those communities. But something that is often talked about is how certain emotions are not okay to show within these communities. Maybe sadness and suicidality is viewed as a sin. Maybe it is viewed as something that is selfish. Maybe it is viewed as something, that you keep quiet. You don't talk about this outside of the home or outside of the family. You need to be extra cautious of this when working with folks from varying communities that might have similar values. Your awareness is what makes you competent. You do not have to be perfect. You have to be aware and curious. And then behavior framed by cultural norms, such as somatic complaints. So when we're thinking about somatic complaints, that's your body complaints. So some cultures express distress through body symptoms. So maybe this is headaches, stomach aches, things of that nature. I'm allowed to talk about having a headache, but I'm not allowed to talk about being suicidal. We have to tune in to some of these things that might be hidden Easter eggs as warning signs. Um, it's also important to think about how stigma may cause people to mask their intent or speak almost in code or like you need to read in between the lines. Something that helps with this is going to be attentive, culturally informed questioning, which I'll talk more about when we get into safety planning. So moving into the assessment space, some cultural considerations to think about is we always want to use open and non-judgmental questions. So instead of things like assumptions, instead of things like, do you identify as gay? You might ask something like, tell me how your identity and community has affected you recently. Someone may disclose to you that they're trans, and you may then choose to say, how does that impact the way that you move in the world? How do your different identities or your intersections and identities impact how you live your day-to-day life? Um, Something else here is asking about identity and experiences of discrimination, supports, and spiritual or cultural resources. This is really multiple things we're asking here. So we want to ask about people's identity. We want to ask about what identities are important to you. What should I know about the identities that you hold in the space that they take for you? But we also want to know about history of discrimination and how stigma has historically impacted their life. Um, eh, Many folks may have never directly experienced discrimination themselves, but maybe they've witnessed it. Maybe it's something that feels really heavy for them because they see it on the news. They see an article on Facebook, right? So, how has experiences of discrimination shown up for you? What is your involvement with discrimination been? Not involvement of like, this is your fault that you were involved here, but more so, how has discrimination shown up in your life and in your lifetime, not just present day, but historically as well? And then on the flip side, there, asking about supports and spiritual or cultural resources right away. So, as we're assessing folks, we're also naturally going to be looking for the things that are risk factors and protective factors. Um, a really important one is don't assume that family is supportive. So if you're doing an assessment with someone and you're like, okay, so let's go through your three support people. Can I write down your mom? Don't make the assumption, always ask. Is your family a supportive thing for you when it comes to your mental health and how you're feeling? Is your family, are your family people that you feel like you can go to when you need support? Or are they people that when you go to for support, you're met with judgment or you're met with a lack of empathy? We have to make sure that we're helping folks identify the appropriate supports in their life instead of just the built-in ones. Folks do not need to rely on family support if it is not healthy and beneficial for them. And then we also want to use validated tools, but adapt language when needed. So when you're using an assessment, it may be very gendered, for example, or it may feel like it really only depicts the white lived experience. Something as a provider that you can do right in the moment is just adapt your language to match what the client's already telling you. So if they tell you, my church is my main support system, as you're going through the rest of your assessment, plug that back in. You mentioned earlier that your church is really supportive. Can you talk to me about what that looks like? Who at church do you usually go to when you're struggling? Have you talked to anyone from your church about your suicidality? Is this something that has felt safe for you to bring up with anyone before this moment? Um, Adapting language is way more powerful than we give credit to, whether that be in your assessments, but also in your intake paperwork. Take a look at your practice or your agency's intake paperwork. Does it list sex assigned at birth and gender, or does it just say sex? Does it dismiss or erase identities that really should be listed? Does your intake paperwork give space for people to not fit into the boxes? Because the reality is that we are serving individual human beings and the boxes don't fit. So utilizing language as an advocacy tool is actually much more powerful than we think about. So keep that in mind too as you bring this information back to your work. Um, how can we just make a simple shift in language to make someone feel so much more safe and supported in the work that we do? Asking about suicide, this is something that even if you do this all day, every day, all of the time, even if you are a crisis social worker, it is still hard. It is still hard to talk directly about suicide. Some things to consider here is that we want to still directly ask about suicide. So, reminder that asking about suicide directly does not increase risk. That is fake news. So, asking about suicide directly is going to start the conversation about what you actually need to be talking about. So, if you're working with someone and they're struggling and you're trying to assess for suicide without directly asking, you may end up missing something, or you may end up meeting with that client who is masking those feelings because of stigma or cultural considerations. So, you want to be direct with that. Some ways that you can make questions more culturally sensitive when talking about suicide are as such. Are you having thoughts about hurting yourself or ending your life? That is neutral, it is not tied to identity. It is a direct way of asking. The next one is a little bit more tied to culture or can be adapted in that way. Has anyone or anything made you feel so hopeless that you thought about dying? This could be, again, every time I open up my phone, every time I open social media, I'm flooded with the next crisis. I'm flooded with the news of people who look like me being deported. I'm flooded with seeing horrific things happen to my community and to the people in it, such as losing our rights in real time. That is something that very likely could make someone feel hopeless and have thoughts about dying. It is important to ask about it. And then how would your community or family respond if you said you needed help? This is going to tell you quite a bit, not just about their support systems, but about their norms within their support systems. This is going to show you, is this person's family a support that we want to lean into, or are they not a safe support? This is also going to show you what stigmas does this person think their community holds about suicide, which again, their viewpoint of the stigma within their own community is the most important. So if they view the stigma within their community as very loud, we need to see that as very loud. Whereas other folks might say, discrimination isn't something I really think about. Okay, I see that that's not something you think about. And there might still be impacts to that discrimination that show up in your life that we're not identifying or connecting to that. There are a lot of different ways that you can alter or adapt language to fit your client. Utilize matching their language. So utilize, especially with like name and pronouns, for example, or titles for partners within the LGBTQ community. Model that language back, mirror it back. So how would your community or family respond if you said you needed help? I'm going to listen there for multiple clues to take away to continue to allow me to show up in a way that is culturally competent and responsive. So if someone says, well, my partner would be really sad but understanding, but my mom would have an absolute cow if she heard me say this. You're going to be able to hear right there, okay, this person has a partner, and that's the terminology that they use to describe that relationship. Noted, gonna use that language. Mom, is this your biological mom? You can ask that. Or, and then they may say, oh, it's my chosen mom. Okay, understandably so. Do you have other parental figures in your life, whether by blood or by community connection? How would those people show up and how would they respond if they knew that you needed help? This also allows the client to work on identifying their support systems as well, so that when crisis strikes, those people are fresh on their mind. Those people are fresh, identified safe people, which sometimes in the depths of suicidality, it's incredibly challenging to remember who is actually in my corner versus who is not. So identifying this together can be a really helpful thing to go back to. Then we're going to talk here about safety planning. I'm sure many of you, if not all of you, are very familiar with safety planning. The picture I have on the screen here is just a very, very basic safety plan. I did not change any of the language here because I want us to think about how we can change the language on any document without it being specified to these populations, because that's how we adapt the language to make it competent. Some things to identify specifically within the safety plan. It's identify culturally meaningful reasons for living. So I gave the example earlier of how powerful it is to see an elder queer person if you are a young queer person. So maybe the culturally meaningful reason for living is I want to be who I needed when I was younger. I want to live past this point so that I can show other queer kids what it's like to be a successful queer adult. That is a beautiful reason for living. And because it is so deeply tied to their culture, it also is going to align with their values. And that the values-based living is something that we know as providers is so powerful. Um, can we build on community and faith-based supports and chosen family? So I'm going to hone in on those chosen people first for supports, not the most convenient people. Obviously, convenience is important when it comes to life or death, but when we are safety planning with someone, this is saying, hey, these are things you can do when you are in crisis or when you are feeling like you are unsafe. We want to make sure that the people we are identifying are the most safe people for this person because the goal of this tool is to utilize it when you are in your lowest of lows. And if I only identify people that are sometimes safe, like biological family, for example, that is not going to serve someone in a crisis. We want to make sure that the supports that we are listing are people that are going to show up and are going to show up safely, competently, and in a way that is comforting for the person struggling. Um, we also want to make sure similarly that we're tailoring the coping skills to be culturally competent too. So the person says, yeah, my church is really important to me. So then later, when you're going through those coping skills and tools, you might ask, hey, earlier you mentioned that your church family is a huge support for you. Would prayer or doing a Bible study be something that you might utilize when you're struggling as a tool to get through that wave? Tying it back to some of those things can be incredibly meaningful. Are there certain music, is there certain music that you like to listen to that makes you feel connected to these things, to these parts of yourself? Are there traditions within your chosen family that you might be able to utilize when you're having a really tough time? And then you always want to make sure that you are including accessible resources. So this is hotlines that are specifically trained to work with these communities. This might also be local affirming clinics. Um, I think that another thing here is that in safety planning across the board, you want it to be incredibly collaborative with the person that you're serving, right? We're making this safety plan for the client, so therefore we want the safety plan to serve the client. So if it's not collaborative in nature, are they actually going to use it? So when the client feels like they have a big role in creating this, I've noticed that they go back to it more frequently. Ask the client or the person what feels realistic to you when you are in crisis. What does that look like for you? How do you know? But also, what's realistic? If it's not realistic for you to go to your church when you are in crisis because you don't have transportation, we're not going to write that on this plan, even if it's a wonderful option. We want these options to be feasible and accessible. In terms of crisis response and referrals, across the top here, you've got kind of just like the flow of what this would look like. So first and foremost, we're going to stabilize the person. So depending on your level of care will depend on if stabilization happens with you or if it happens outside of your agency. Then we're going to assess. After we're assessing, we're safety planning and potentially hospitalizing. Now we're on to the referral stage here. So within the referral stage, some things that are going to be really helpful to know is first and foremost, a referral is only useful if the provider is culturally safe. I'm going to say that again. A referral is only useful if the provider is culturally safe. So if I am working with someone who is struggling with suicidality, let's say that they don't have a plan, they don't have intent, so we're able to make a safety plan together and then talk through, okay, maybe it's time for you to meet with a psychiatrist. How just challenging and honestly disappointing and heartbreaking it can be to refer your client who is actively struggling to another provider, whether that be for med management, OBGYN, primary care, and then your client come back to you and say, wow, that was a really awful experience. That person did not feel safe. So a referral is not just a referral in this case. It is not just, oh, here's the number to the clinic down the street. It's critical and crucial that you are checking with others in the field. You are maybe sussing out or scoping out these other providers yourself before sending your clients to them. It's just really, really important that you're ensuring safety amongst the referrals that you're given. Um, Also within referrals, we're going to use trauma-informed and identity-affirming language. So again, I am going to use the language that the client utilizes in terms of how they identify. You're going to always, when possible, I understand that there are going to be barriers to getting folks to a culturally competent provider or someone who specializes in working with their communities, such as rural communities, don't have as much access to these types of specialty clinicians or providers. Um, However, the more you can prioritize connection with affirming providers and community supports, the better you are, the better your client is. So knowing your local resources is one of the best things that you can do as an advocate and also as a competent provider. Um, at the end of our presentation today, I do have some Kansas City metro area specific referrals listed to give you some of those hotlines, clinics, peer groups, etc., even as just a starting point. And then ensuring follow-up and continuity. So ensuring follow-up yourself with that client, but in a perfect world, ensuring follow-up happened with the other provider. Did you get to see the psychiatrist? What was that experience like for you? Did you feel safe there? Are some of the things that I tend to ask my clients when they come see me after they've been referred to another type of service as well. A couple of interventions when talking about suicidality, risk, and responsiveness with some cultural adaptations. This is not an all-inclusive list by any means. This is actually quite small, but it's a baseline. So CBT and DBT can both be culturally adapted fairly easily through language, metaphors, and then the values that we're highlighting. So for example, using family and community narratives in CBT. Maybe when you're doing reframing within CBT, you're reframing how stigma is not made up and how we need to have grace and gentleness with ourselves for feeling fear of seeing a new provider or feeling the depths of despair of living in a world that feels out to get you. Utilizing specific examples of the supports or the tools that they've shared in other sessions or conversations can be easily tied into CBT or DBT as well. Excuse me. I already talked about collaborative safety planning, but one more push for that. Safety plans are the most effective when it's a group effort. Also, in a perfect world, the support people that are being listed on the safety plan are being contacted. So I always like to encourage my clients to contact their support people and say, hey, I've identified you as a support person for when I'm in crisis. This is what that means. This is what that looks like. This is what I need from you if that happens. Not only is that collaborative, but it also gives your client a ton of autonomy to utilize the plan in the way that feels best to them. Culturally adapted group interventions and peer support. Maybe you are working with a family and within the family, multiple generations live in the home with your client. So maybe you are offering a family session with all of these different family members to come and work on that safety plan collaboration together, or teach them skills and tools for how to be supports in that moment for your client or the person that you're working with. Just thinking about in general, how does this person exist within the world? How does the world and their relationships impact how they feel, the experiences they have, the opportunities they are granted or not, and trying to pull those things into any of your interventions. I'm a really big fan of using like the values cards. It's one of my favorite tools in therapy in general. But using this from a culturally competent lens can be super cool because you might notice that different communities value different things. But identifying those values for a person as an individual can allow them to see, okay, how can I live aligned with my values? Will I feel better? Will it feel like I have more of a say-so in my life if I am living aligned with my values? Will I be able to set more boundaries and protect my peace more if I understand what I value and where that comes from? And then community-based healing practices integrated with clinical care. So this might be clinical support groups specifically for BIPOC folks or LGBTQ people. There's a lot of different ways that that can look, but essentially what I'm referring to is the mashup between community care and clinical care. Community care is wonderful, but it's not always enough. Clinical care is wonderful, but it's not always enough. Morphing the two together is perfect world. So on this slide here, I've got a case vignette that I want us to explore together. Um, This is going to look a little bit different because this is a pre-recorded video. However, the idea here is that I've got a case study identified featuring a 17-year-old Latinx trans masculine teen. So we've got some intersections there. Recently has experienced school bullying, family religious conflict. They are presenting as withdrawn, and there is some intermittent self-harm. You've got some background in context here, and then some cultural functioning just to give you an overview of what's going on with this client. So background and context. Alex was referred to counseling after teachers and peers noticed signs of distress at school, including avoidance of social situations, frequent absences, and changes in mood. Alex identifies as trans masculine and uses he, they pronouns. Over the past several months, he has experienced targeted bullying at school related to both gender expression and cultural identity. Peers have made derogatory comments, misgendered him, and circulated rumors, resulting in heightened anxiety, social isolation, and decreased participation in all school activities. At home, Alex's family is deeply religious and struggles to reconcile his gender identity with their beliefs. This has resulted in frequent arguments and feelings of rejection, leading Alex to avoid sharing personal experience with family members. Alex reports feeling caught between being safe and being loved, and has described moments of intense shame and sadness. Alex's current functioning. So Alex has become increasingly withdrawn, limiting contact with peers and family, and spends much of his time alone in his room. He reports persistent low mood, feelings of worthlessness, and a sense of not belonging. There are intermittent incidents of self-harm, primarily superficial cutting on the forearms, which Alex describes as a way to release emotional pain when he feels overwhelmed. He denies current suicidal intent, but acknowledges fleeting thoughts of not wanting to exist during periods of intense stress. On this next slide, we're going to go through some discussion questions. Now that we've talked through the assessment options, safety planning, referrals, and viewing all of that from a culturally responsive lens, the idea here is that I want us to apply all of those ideas to this case. So on this slide here, I welcome you to pause the video at this time and ask yourself the following questions. So you're going to ask yourself, what cultural or systemic factors increased the risk in this example? Which protective factors could be activated or identified for Alex? And then how would you assess and safety plan specifically when working with this person? So again, I'll ask you now to take a moment to pause your video and really just reflect on this case vignette and how you as a provider would show up when working with Alex. We'll pause now. Okay, and welcome back. Next, what we are going to do is I've broken this down for you just a little bit to give some feedback about that case. So strengths and protective factors, starting there, what I know based on the case vignette is that Alex demonstrates resilience by maintaining at least some school attendance despite bullying. So he is still showing up or trying to. Alex has a few supportive friends who respect his pronouns and identity. Um, if we don't know that for sure from the case vignette, this is something you could also ask, right? So if you're working with Alex and you have this information, you may say, hey, like you mentioned that people are misgendering you or dead naming you at school. Do you have some people at school who are not doing that, who are respecting your pronouns and your identity? Um, Some other strengths and protective factors that you might explore with Alex are expressive interest. Are they into drawing or journaling? Has Alex looked into online LGBTQ plus communities? There are a lot of teens on Discord, and there's a million and one different channels. Obviously, the internet is not always safe, but it is absolutely a resource that's accessible. And so we lean into that when we can, and when sometimes that is the best thing you can offer. It may be the only thing you can offer. Um, all of these things can provide Alex with emotional outlets and some coping mechanisms. If Alex is interested in drawing or journaling, that's also a great thing that he can lean into when having the urge to self-harm. You could connect those things together. Some other clinical considerations here is that the intersection of trans identity, Latinx cultural context, and religious family dynamics heightens that minority stress here for Alex tenfold, right? Like when you go back to that intersectionality, the overlap of all of the bubbles, Alex is really in several of these. And so I mentioned earlier that one of these populations struggles with stigma or discrimination. The more you add, the more layered that minority stress gets. Alex might benefit from affirming trauma-informed interventions that address both external bullying, but also internalized stigma. Exploring that internalized stigma. What is the narrative that you have about your identity? How do you feel about who you are? Safety planning and ongoing risk assessment for the self-harm is obviously critical in this example. And then if any way possible, we could safely engage the family here would be awesome. So family engagement might be approached cautiously because again, we've got this religious factor going on here. But emphasizing psychoeducation about gender identity and linkage to mental health could be a way to go about it. Of course, you would want to make sure that Alex is okay with this, and you would want to explain to Alex that your goal is to be a liaison and to share information. Sometimes it's easier for parents or family members to hear it from the professional than it is to hear it from their own kid. Um, explaining that to Alex up front and getting his consent and permission for family engagement is also critical here, unless, of course, you're at a point where you don't have choice because he's a risk to himself or others. But in the case vignette, at this point in time, Alex safety planning with Alex and creating different coping strategies and tools and working through some of the stress is a great starting point. You don't necessarily have to pull in family engagement. You could also build up to that, help Alex work through that, work through some of the internalized stigma first, and then talk more about bringing family in as potential supports. You also may consider doing chosen family in that case. You may consider asking, is there a safe adult in your life that you would want to bring, like in my case, to therapy, um, giving as much collaboration and choice as possible. Um, Rounding us out here with some practical tips for providers, our do's and don'ts. So we do want to practice cultural humility, ask and listen, show up with curiosity instead of judgment. It is normal to have your own preconceived ideas about communities that you are not a part of. It is also your job to work on dismantling those ideas within your own brain. Using affirming name and pronouns always. Always. You might be the only person on this planet that calls that person by their correct name and pronouns. That is a very powerful thing. If you make a mistake, correct yourself gracefully. Something I see often is, oh my gosh, I'm so sorry. Oh gosh, I can't, I just can't get it with the they, them pronouns. Oh gosh. While your intention is apologizing, what you're doing there is actually making it about you. Uh, I'm so sorry that I dead named you. Let me tell you how awful I feel about it. That is not what we're trying to do there. So a way that that could look is you just quickly correct. So let's say this person, going back to our example of Alex, Alex uses he, they as pronouns. So let's say you accidentally use she as a pronoun, you're going to quickly switch. You're going to say, she blah blah blah, they blah blah blah. You're just going to naturally in the moment switch the word. We don't have to make it a big scene or an ordeal. But correcting your mistakes will naturally help you get better at utilizing different pronouns if that's something that's challenging. But it also will show that client that you get it and you hear them and you are trying. And then please do partner with community organizations. I'll get to that list here in a second of local organizations, but the there is too much work and not enough people. So we have got to figure out ways that we can continue to partner and work together with folks that are in the same spaces doing the same types of work as us. Having a direct referral network is also really wonderful when you have those folks that you know are affirming that you can directly refer to. So build those connections and networks. Don't make assumptions about values or supports. So, something that I do in my work in regard to that is I will say something like, um, I never want to assume your experience or your life. Like, you are the expert in your life. And I also know XYZ thing about your community. Does that apply to you, right? So sometimes I'll say something like, I understand that within the Latinx community, talking about mental health can be really shameful. While I don't want to assume your own lived experience, is that something that applies to you or that you have experienced or felt? That shows them that A, you have a baseline understanding of their community, but it also opens the door for those connections to be made of like, oh my gosh, like yeah, I feel like I can't talk about this stuff at home because anytime I've ever brought up being sad or suicidal, I'm met with, well, did you pray about it? And I'm needing something different right now. So there are a lot of different ways to bring up the uh, the values or things that may be attached to that community without assuming that that applies to every person. Um, don't minimize reports of discrimination. If someone reports discrimination to you, we're not going to just be like, oh, wow, that really sucked. No, you're going to draw, I don't want to say draw attention to it, but we're going to hold space for it and say, wow, that must have been incredibly hard. Oh my gosh, like I can't imagine what it must have felt like for you in that moment. Thank you so much for telling me. And it makes sense to me that you're not very open about these topics with other people or that you've struggled to share this. We want to validate because unfortunately society erases a lot of that discrimination and pretends that it doesn't happen. And so if someone is bringing that to you, the last thing you want to do is minimize that report. And then lastly, please, please do not refer without verifying cultural safety first. It is just the fact of the matter is that it can be dangerous to refer someone to a not culturally safe space or practice or provider. And part of our job, especially when talking about suicidality and safety planning, is keeping folks safe. And that means in every way, shape, and form. So now I'm into our resources and supports. This is more nationwide. Feel free to take a picture of this screenshot, do whatever you need to do. But the first half here are national hotlines and specific LGBTQ crisis lines. Um, it's also important right now as there's a lot of different funding cuts happening from the federal level that you're keeping an eye on any of these resources that might be disappearing or losing funding and no longer able to stay as a service. But as of right now, here are some of the most common ones. The second half here are some BIPOC mental health organizations and directories. So you've got several different options that are provider directories, but are also specific to the BIPOC communities. Um, but then on this next page, this is for the Kansas City Metro specifically. Um, I've got a collection here of both uh, resources for LGBTQ folks as well as BIPOC folks. So again, feel free to take a screenshot of this. I'm not going to read through each of these different resources. Just know that these are ones that I personally have vetted and feel good about sharing and referring. So shout out to these resources. And I'm sure there are many, many more. These are some references, which again, I'm not going to read out loud. And that actually concludes our presentation today. So at this time, I would just like to thank you for being a part of Care for You 2 2025, continuing your education. And I want you to remember that your work really matters, what you are doing matters, and making a safe space for someone matters. So thank you for your continued commitment. And I am honored to work with all of you.